Hi, I'm here at Maui Derm. We're talking about chronic spontaneous urticaria, and actually all types of urticaria. And this is an exciting topic. Me having urticaria for over 15 years, chronic cold urticaria, this was something that I learned early on, that these patients really had disease symptoms that we needed to recognize and treat, and often these interfere with all sorts of daily activities. But interestingly, these are patients that have been traditionally treated by our allergy colleagues, and a lot of that is based in some of this misunderstanding. But we go back to some of the basics when we talk about the different types of urticaria, particularly that 80% of our chronic cases are chronic spontaneous urticaria, also known as chronic idiopathic urticaria. So by definition, these are patients who don't have an underlying cause. So sending them to an allergist to do testing doesn't make a lot of sense. That's different from our acute urticaria cases that often have triggers, infections, medications, immunizations. So when we're talking about these chronic patients who have already usually tried to tease out some of the triggers of their disease, by the time they get to us, they really just want relief. But we've been giving these patients away to allergy primarily because of omalizumab, which has been a medication that's been often given by our allergy colleagues concerning dermatology because of course, the black box warning. But we're seeing a change in the tides now. We're getting new medications, new therapies. We have some familiar therapies, particularly those in the IL-4/13 space. So with dupilumab, for example, we now have a pretty robust clinical trial program, 3 studies in the phase 3 level looking at the patients with CSU's response to blockade of type 2 inflammation. And this is really a paradigm shift from where we used to be with our understanding of the IgE-mediated diseases and the mast cell activation, which is why omalizumab had a lot of interest. But we're starting to tease out some of the new mechanisms that can activate these mast cells and cause that degranulation, which is going to lead to some of the clinical symptoms. And we now know that there are patients who have mast cell mediated urticaria that's independent of IgE. So we're looking at these new mechanisms, things that are blocking other antibody formation, which is where dupilumab comes in with the class switching with IL-4 and driving some of the other antibody formation. And then we're also looking at new mechanisms with remibrutinib, an oral small molecule, which can inhibit the BTK pathway inside the mast cells, which can drive activation. And we can see that that pathway can be activated through multiple mechanisms, also independent of IgE, but also is going to hit those patients that have IgE-mediated disease. So we're now moving into new therapeutics, should work better in most cases. We're also seeing improvement that's fast. We have oral medication with remibrutinib. It's fast acting, it's a rapid onset, works in patients with both wheals and angioedema, multiple mechanisms. So there's a chance for dermatology to recapture this group of patients. We outnumber the allergist colleagues by 3 to 4 times. These patients need good medical care, and this is a skin disease coming back to dermatology. And I hope you'll start to look for these patients. Be on the lookout for these new upcoming medications. They're going to add to our armamentarium that we can offer these patients to give them relief. Thanks.